Welcome, focus learners. You are tuning in to a high-yield medical explainer breaking down the pathophysiology and clinical presentation of otosclerosis. I'm your host, and today we're strictly sticking to the established clinical data to bring you absolute crystal-clear clarity on this condition. Whether you're gearing up for board exams or you just need a really definitive, authoritative review of this disease, well, you're in exactly the right place. Let's get right into it.
Right off the bat, I want you to consider this clinical scenario. Imagine a patient who walks into your clinic and tells you that they can actually hear conversations better when they're in a loud, chaotic, crowded room compared to a perfectly quiet environment. Now, why on earth does that happen? This kind of paradoxical phenomenon is known as paracusis willisi, and it's a classic, absolute hallmark of the disease we're breaking down today. But before we solve exactly why that happens, let's quickly map out the structure of today's explainer.
Here is exactly what we're covering. Section 1 is definition and ear anatomy. Section 2, causes and risk factors. Section 3 covers pathology and types. Section 4, symptoms and clinical signs. Then we hit Section 5, diagnosis and audiometry. And finally, Section 6, treatment options. All right, Section 1, definition and ear anatomy, the foundation.
So the term otosclerosis is actually a bit of a misnomer. Clinically speaking, you'll often hear it referred to as otospongiosis, which honestly makes more sense. It's a primary disease of the bony labyrinth, or the otic capsule. And the fundamental pathophysiology here is that your normal, incredibly dense bone is pathologically replaced by irregular, spongy bone. I want you to literally highlight those words in your mind. Irregular, spongy bone. This spongy bone most commonly targets the stapes region, locking it down completely. We call this stapes fixation, and because the mechanical transmission of sound is physically blocked, this directly causes a conductive hearing loss.
To understand this, let's look at the real estate. The inner ear consists of the otic labyrinth, also known as the membranous labyrinth, which is filled with endolymph and houses structures like the utricle, saccule, and cochlea. Surrounding all of that is the periotic, or perilymphatic labyrinth, which, you guessed it, is filled with perilymph. But this disease, it actually originates in the solid bony casing housing all of this, the otic capsule. Now, the otic capsule has 3 layers, the inner endostele, the middle endochondral, and the outer periosteal. It is specifically right there within that middle endochondral layer where otosclerosis is born. Moving on to Section 2, causes and risk factors. Who exactly is at risk here? The data we have on demographics and heredity is super testable, so lock this in. Genetically, otosclerosis follows an autosomal dominant inheritance pattern. However, it's a bit tricky because it shows incomplete penetrance and variable expressivity. Despite that, nearly 50% of cases are going to walk in with a positive family history. As for onset, it usually hits between the ages of 20 and 30. It's actually incredibly rare to see this before age 10 or after age 40. On top of that, there's a massive sex predilection. Females are affected twice as often as males. And crucially, hormonal shifts, like those during pregnancy or menopause, can drastically accelerate and worsen the hearing loss. Now, let's talk about the primary site of predilection. The exact anatomical sweet spot where this disease prefers to kick off is called the fistula antefenestrum. This is a tiny cleft of embryonic cartilage that sits right in front of the oval window. Look, when you see a board question asking for the initial site of stapedial otosclerosis, fistula antefenestrum is your essential, non-negotiable answer. Let's transition to Section 3, pathology and types, specifically stapedial, cochlear, and histologic. We categorize this disease into 3 really distinct types. First up is stapedial otosclerosis. This is by far the most common type. It involves the stapes footplate, causes that stapes fixation we talked about, and leaves the patient with a purely conductive deafness. Second is cochlear otosclerosis. Here, the spongy bone goes rogue and involves the round window or the deeper otic capsule. This messes with the inner ear mechanics directly, causing sensory neural hearing loss. And finally, we have histologic otosclerosis. This type, completely asymptomatic. The lesions are definitely there on a microscopic level, but they haven't progressed enough to cause any conductive or sensory neural deficits. Now, if we look at the pathology at a microscopic level, you'll see how the disease evolves. An active, immature lesion is highly cellular. It's packed with vascular spaces, marrow spaces, osteoblasts aggressively building bone, and osteoclasts breaking it down. Because it produces a specific cement substance, it actually stains blue. We call these blue mantles.
In stark contrast, as the disease progresses into a mature lesion, the vascularity totally drops off. Bone formation ramps up with dense, fibrillar substance, and under the microscope it notably stains red.
All right, Section 4. Symptoms and clinical signs. What does the patient actually present with? So the absolute hallmark symptom here is an insidious, progressive, and completely painless hearing loss. It's usually bilateral, and like we said, it starts creeping up in the patient's 20s. Now let's circle back to that opening hook, paracusis Willis C. The patient actually hears better in noise. Why? Well, it's simple. People with normal hearing naturally speak louder to overpower background noise, right? But our otosclerosis patient is totally protected from that background noise by their conductive block. So to them, those naturally raised voices come through loud and clear. You'll also see tinnitus, especially in active or cochlear lesions. Plus, these patients often develop a really distinct, soft, monotonous speech pattern. Because of their conductive loss, their own voice sounds deceptively loud to them through bone conduction, so they subconsciously whisper. Okay, this next part is a crucial physical exam finding. The tympanic membrane itself is going to look completely normal and perfectly mobile. However, in about 10% of cases, you're going to observe what's called the short sign. This is a very distinct reddish hue seen on the promontory, right through that translucent tympanic membrane. That red glow, it's literally the highly vascular, active, otosclerotic focus we discussed earlier shining through. Lock this finding firmly into your memory.
Moving into Section 5, Diagnosis and Audiometry. Testing the fixation.
When you bust out the tuning forks, the Rinne test is going to be negative. That means bone conduction is now outperforming air conduction simply because the stapes is locked up. But here's what's so cool. This test brilliantly illustrates the disease's progression. The negative result follows a very precise sequence. First, it turns negative for the low-frequency 256 Hz tuning fork. Then, as the stapes becomes more and more rigidly fixed, it turns negative for the 512 Hz fork. Finally, when the fixation is complete, it goes negative for the 1024 Hz fork. The Weber test, as you'd expect, will just lateralize to the ear with a heavier conductive loss.
Now, when you run pure tone audiometry, you're going to spot a really classic phenomenon in the bone conduction curve. The absolute defining number you need to remember right here is 2000. Carhart's notch is an artifactual dip in the bone conduction curve, and it reaches its maximum depression exactly at 2000 Hz.
To be strictly precise with the clinical data here, Carhart's notch presents an artificial depression of bone conduction thresholds across a few frequencies. The decibel drop is 5 decibels at 500 Hz, 10 decibels at 1000 Hz, hits that maximum 15 decibel drop right at 2000 Hz, and then returns to a 5 decibel drop at 4000 Hz. Interestingly, this notch reliably vanishes after a successful surgery. Also, since the stapes is essentially cemented into the bone, tympanometry is going to show severe osticular stiffness, and the stapedial reflex, completely absent.
Finally, Section 6, Treatment Options. How do we bypass the fixation?
First off, we need to be clear, there is no real medical cure for otosclerosis. Medical treatments like giving sodium fluoride to try and halt bone remodeling, well, they're highly controversial and generally just not recommended in modern practice. Because of that, the definitive treatment of choice is purely surgical. The primary procedures we're looking at are a stapedectomy or a stapetotomy. The entire goal is straightforward mechanical engineering. Remove or bypass the fixed stapes bone entirely and restore the mechanical chain of sound transmission. So during a stapetotomy, the surgeon literally places a microprosthesis right between the mobile incus bone and the oval window, physically bypassing that frozen stapes footplate. And we have a few advanced materials used for these prostheses. You'll typically see a standard Teflon piston, a stainless steel piston, a platinum Teflon combo, or a titanium Teflon piston. The ultimate choice basically just comes down to the surgeon's personal preference and whatever specific anatomic quirks they encounter once they're actually in the middle ear.
All right, before we totally wrap up this explainer, let's do a quick high-yield knowledge check. What specific clinical triad defines van der Hoof syndrome? The answer? It's the simultaneous presentation of osteogenesis imperfecta, otosclerosis, and blue sclera. Just take a second to consider how a massive systemic bone dysplasia manifests so profoundly in a space as unimaginably tiny as the middle ear. Master these high-yield facts, and you will understand the mechanics of otosclerosis completely. Until our next explainer, stay focused and keep learning.